Our next patient is a 59-year-old female, and she had a prior right excisional biopsy. Again, it was years ago, back in 1997. And this was her mammogram that she came in for, and you can see the scar marker with the area of distortion in the right lateral breast. And here's her scar marker with a distortion seen in the superior aspect and the medial lateral blank. So this year, you can see the scar marker here with the area of distortion. And there's the area of distortion from her scar. There was a second area that was not appreciated this year and was missed, was looked over. The following year, she came back. And again, here's the scar marker. You can see here, but medial to that area of distortion, there's a new area that has formed that we didn't appreciate the year prior. And again, it's inferior, very far away from the surgical scar. So again, this is why it's very important. Somebody, I think, erroneously thought the year prior that that was just part of the surgical scarring. But again, we can clearly see the scar is not in the area of the distortion. And this is a new lesion that is formed clear, very far away, inferior from this post-surgical scarring. And here's a post-biopsy mammogram after we did an ultrasound-guided biopsy of the area. And you can, again, see the distance that it's far away on those images. And here's a specimen, again, just showing the area. There were a few little calcifications that we didn't really appreciate in this new lesion. And this turned out to be an invasive ductal carcinoma. So again, it's very important. And I think had we really honed in on the fact that they did not correlate, there was a new area that was seen that was not scarring, that we would have maybe caught it the year prior. But thankfully, we were able to catch it at this time and recognize that it was not surgical scarring, but it was unfortunately a new cancer for this patient.